Well, hey, everybody. I know people are collecting, but Kim, you're in Las Vegas. What's the temperature in Las Vegas tonight?
Oh my gosh, it's been chilly here. I think we're in the 50s right now.
hmm And we have a very cold 57 here in St. Petersburg. Laura, how about in Parrish? Probably about the same.
About the same, which
Yeah.
originally from Ohio. I don't know what happens to your temperature system as a human. It is amazing that I would think this is warm, 57, be like, oh, that's warm still. And
Yeah.
now I'm like freezing. Where's the blankets?
Well, tell us what the temperature is where you all are. Put it in the chat or just speak up. We'd love to hear.
Hello, this is Dr. Matosian from California.
Yes. Yeah. Hey.
How
How's
are
the
you?
temperature out there? We're great. How's the temperature out there?
I hate to rub it in, but it's really nice.
It's always nice in California. Yes, it really is.
Hi, everyone. It is 41 degrees in hot Atlanta, cold Atlanta.
Oh, that is cold, Janice. Yeah, that is cold. And 48 in Nebraska, which is warm. Yeah. And 37 in Brooklyn, which is chilly. In fact, I heard it was supposed to snow there tonight, I think. My wife and daughter and granddaughter are heading up tomorrow for 4 days. No boys allowed. Yeah.
Girls trip, huh?
Girls trip only. Yeah, that happens a lot. And I work.
46 in Augusta.
It's what in Augusta?
46.
Okay. All right. 53 in Bradenton Lakewood Ranch area with Allison. And Nag said North Carolina is 45. That's cold.
Yeah. Augusta is real close to Aiken, South Carolina. And I shared with Tal and Leah's practice, the IDM concept.
Good. Oh, good, Mike. That's wonderful. You're doing amazing work, gosh, as we all would expect. Well, we're just waiting for a few more people to collect and we'll get rolling here in about 2 minutes. But happy holidays, everybody. We're into December. It goes so fast. Goes so fast. They have a channel here in Florida that is playing Christmas music starting the day after Thanksgiving. I've got it blaring in my car. 34 in Dayton. That's up your way, Laura, where Dan is. 42 in Tennessee. So it's chilly everywhere. Do you miss the Ohio weather, Laura?
No, but Jack, my little one who's 13, said it just doesn't feel like the holidays here. It does not feel like Christmas is coming. So it's a different perspective, that's for sure.
You turn the air down.
I told him we can buy those little fake snowballs. I'm curious if anyone has snow yet. Anyone seen snow? 35 in Chicago, Ohio, and
Close
Chicago.
Chicago. Yeah. We were over at Gaylord Palms in Orlando at Disney this weekend, and they have a display in the hotel called Ice. And you go in, they give you overcoats, and they have ice sculptures all through. And it was Charlie Brown, and they color the ice, and it's amazing. And it's 9 degrees in there. And you go through several rooms, and it's really cold. So that was in Orlando.
I know where to send Jack. Thanks. That's where we'll send him. 9 degrees. Get his
Be disappointed. The thing is, they gave you like an overcoat winter jacket, but no gloves and no pockets, and your hands got really cold.
I bet. No.
Yes, snow in Chicago already. How about that? We'll be up there in February. for the midwinter. Well, it's almost 5 after, so I think we'll go ahead and get started. I'm going to share my screen with everyone, hopefully. Let's see here. And we'll talk about what we're going to do tonight. So a lot has happened since we've been together 2 months ago. And we have actually completed 2 new courses, the online Airway course and the online TMD course. We have some new things happening that I'll share with you at the end of our discussion tonight that are some exciting new adventures that we're getting ready to team up with other groups on, which I want you all to know about, something that Laura and Gina and I have been very involved with, a university that wants to implement the whole IDM model for their students, and we'll share with that, well, a little bit more with you about that when we finish up later tonight. But what I wanted to talk about tonight, because we really haven't had this discussion in any depth on our study club meetings, is about the subject of TMD. And of course, that's one of our 3 pillars of integrative dental medicine. The reason being that the understanding of the masticatory system, that is the jaw system, the joints, the muscles, the occlusion, which is historically what we've referred to, now has been expanded into understanding also about the airway, which has become a critical component of the masticatory system as a functioning system or dysfunctioning system in some cases. And then there is no other specialty in medicine that really addresses the subject of the temporomandibular joints, of dental occlusion. Only we are experts in that area, or should be. All of us have had patients referred to us or referred back to us by their physician saying, well, you know, you don't have an ear infection. I'm not sure what's going on there. Go see your dentist. Maybe you have TMD. And so I want to talk about that tonight and just give you a little preview of what we've created on this online course that actually became available December 1st. So it's hot off the press, and hope that is one that you all will watch at home and learn from it and get your foundation well established in that pillar as well. And so with that, the foundations course on TMD and dental occlusion disorders has 12 different chapters or sessions in it. And the first session is about understanding what is TMD. And so I thought I would pick up a portion of that first session and talk about it in our study club meeting. And then you bring up those things that you would like to talk about that maybe you're uncertain about, or things that you're thinking about. How do these things integrate together, and how do we implement these things in our clinical practices? So with that, I want to introduce this subject by sharing with you something that I did not very long ago. I'm on staff at a local city hospital in St. Petersburg, Florida, called St. Anthony's Hospital. And I was called by the chief of staff there and asked if I would do a grand rounds lunch program for the doctors, the MDs, and the nurses at the hospital who wanted to understand what is TMD and how do you treat it. And so what I think we'll do tonight is I'm going to present to you what I presented to the physicians and the nurses at the hospital. And perhaps it's something that you can use as you begin to talk in your community about dentistry and dentistry's role in complete health and the oral systemic connection and these things. So let me share with you how we approach this at those grand rounds at St. Anthony's Hospital. Basically, what I did was I told them that there are a number of subjects that often come up when it comes to temporomandibular disorders. And what I'd like to do is pick 9 topics that are the most common ones that we hear asked about, and then discuss them one by one. So the 9 topics are: what are the causes of pain in the temporomandibular joint? What limits the jaw from opening fully and may cause locking of the jaw? What is this thing of popping, clicking, or grating sounds in the joint when opening and closing? What's that all about? Also, what about ear pain and tinnitus or tinnitus? Is there a relationship between the temporomandibular joint and problems there and ear pain or tinnitus? Another question would be, how is TMJ a major cause of headaches and related to neck pain as well? And a 6th subject would be, what's the impact of airway obstructions on the temporomandibular joint and temporomandibular disorders? Another topic, number 7, would be bruxism. What are the causes and effects of clenching and grinding your teeth? And then finally, the last 2 topics would be, what are the non-surgical management tools that we have to treat TMJ disorders? And what are the surgical management strategies as well? And so why don't we go through these? Maybe you have answers to all 9 of these, or maybe not. And so let me share with you from my experience and background what the answers would be that I would give. And by the way, since some of us are still getting to know each other, let me just share quickly my background on this topic. In 1981, at the end of 1981, I was invited to come practice with Dr. Pete Dawson here in St. Petersburg, in a practice that was probably the busiest restorative dentistry practice in the world. One of the things that was a new topic in 1980-81 was the topic of TMJ or TMD. It was so new that we had no imaging of the joints. There was very little that we knew. We knew that joints popped and clicked. We knew that people had pain in their joints. We knew that there was a disc in there that sometimes could get misplaced and cause problems. We knew sometimes when those things occurred, the bite would shift and open up in the front from teeth that touched to teeth that didn't touch in the front. And so with all of these things, our practice in St. Petersburg began because of Dr. Dawson's expertise to have a lot of referrals for TMD. Dentists from all over the United States and actually beyond the United States were sending patients to St. Petersburg to get treated, to the point where it was just inundating our practice. And so Dr. Dawson spoke with me before I came to practice with him and said, this is an area that I would like for you to focus on. And in fact, the world's expert on this subject is Dr. Parker Mahan, who heads the Facial Pain Center at the University of Florida, where I was, and has developed a pain center. He's written a book entitled Facial Pain. And Dr. Dawson said, I would like for you to spend 6 months with him, studying with him, being mentored by him. And then when you come to St. Petersburg, this was in December, when you come to St. Petersburg in June, you can become our TMD specialist. Well, I was 27 years old, and I really wasn't too excited about that proposition, but that's exactly what ended up happening. So I spent 6 months with Dr. Mahan, who was the world's authority at that time, then came and worked with Dr. Dawson, who also was an authority. But all of the patients that came into our practice were then handed off to me to manage. Fortunately, in 1983, the year after I arrived, Dr. Mark Piper, who is a physician and TMJ surgeon, came and joined our group right out of his residency at Harvard and at Vanderbilt University. And so I was fortunate to be able to see hundreds and literally hundreds of patients with Dr. Piper, many of whom who had TMJ surgery. I would manage their occlusions. I would manage their splint therapy before and after surgery, and then manage their occlusal definitive therapy after they were considered to be healed, typically about 6 months after surgery. So through the last 40 years, I've seen literally several thousand referred TMJ patients, meaning the real problem ones, many of whom needed surgery, who had chronic facial pain, who had been unresolved through other attempts and seeing other specialists, dentists, and physicians and otherwise. And so this subject to me is very comfortable and kind of like riding a bicycle. I've seen it all many, many times over. And so let's talk about it. And we'll start with what are the causes of pain in the temporomandibular joint. When we talk about this, we want to think about the joint itself and how it's built. And in this course that you will take, we will go through in great detail the anatomy of the joint and how the joint functions. That's very much the starting point. No different than if you were going to be an automobile mechanic. The first thing you'd have to understand is, how is the car put together? How does the engine run? You know, what are all these parts and what do they do? So that when there's a problem, you understand what are the possibilities. And in the temporomandibular joint, there's only a couple possibilities of what can go wrong or what can cause pain. The most common one would be that as you look at this illustration of the joint and you see the condyle or the ball sitting in the socket or the fossa, and between the ball and the socket is soft tissue. And interposed between those two bone surfaces is a soft tissue pad called the disc. And that disc is a shock absorber that's intended to protect the joint for a lifetime. When someone has normal joint alignment and normal disc alignment, then typically you're not going to have pain in that joint. So the most typical cause for pain in the joint is when the disc actually gets displaced. Its attachments through ligaments is lost either through tears or stretching or migration. And you develop a disc that may slip, just like in your neck or in your back vertebrae. And this slipped disc, which always slips anteriorly, so we call it an anteriorly displaced disc, is a problem that can create a great deal of discomfort in the joint. Because as you see the diagram or illustration that you're looking at now as you look at the ball and the socket, you see a red colored tissue interposed between the two bones. And this is what's called the retrodiscal tissue, the behind the disc tissue that is full of nerves and full of blood vessels. And so when that tissue is now superior or above the condyle and the patient closes their mouth, they're impinging on nerves and blood vessels that can create a significant amount of discomfort in some people. So that would be the number one cause for pain in front of the ear in the temporomandibular joint. We have ways of looking at the joint now that we didn't have in 1982 when I was learning about this. And today, nothing can hide from us, literally. And so if someone has pain in the joint, we can figure out why very quickly. And one of the greatest aids that we have or tools that we have today is the magnetic resonance imaging. And so with that, you can see not only hard tissue, but you can see soft tissue as well. And on the right, on this image, you see I've outlined and pointed with arrows to the area where the disc is. And so is the disc interposed between the ball and the socket, between the condyle and the fossa? And in this case, it is. And so as the illustration on the left shows the disc in blue, and on the right, you see it on an MRI, you see that we can identify and study exactly where that position is. And so imaging has become a big part of our ability to diagnose and understand pain in the temporomandibular joint and stability or instability in the joint. So on the images that you see on the screen right now, on the left-hand side, you see the arrow, and I'm going to outline, there's where the disc is. Now, the disc should be right on top of the socket, that black outlined structure that I'm showing. It should be on top of, and the right-hand portion of that disc should be sitting at about 1 o'clock on top of the condyle or the ball, if that was a clock. And so 1 o'clock would be proper. You can see the back end or the posterior band of this disc is sitting at about 9 o'clock because it's completely out of place. Now, when this patient opens, in this case, in that joint, you would hear a click. And the reason you hear a click is because the disc is being recaptured, or we call it being reduced, which means it's popping back onto the disc. So on the right-hand screen, you can see that the condyle has moved down and forward down toward the end of the eminence or the fossa. And if I circle for you here, there you go, there's the disc. So that disc that was in front or anteriorly displaced in a closed position now is on top. And so it's clicked or it's recaptured or it's reduced back onto the condyle. On the lower images that you see, another case study, you see the arrow on the lower left image. And if I outline, there's the disc. And you can see it's way out of position. It wouldn't be surprising at all if this patient said that joint hurt a lot, as would be true on the one on the top too, when they bite down off the disc. On the lower case, as they open their mouth, look what happens. The disc just gets pushed farther forward. It doesn't recapture. There's no clicking. They probably used to click, but they can't anymore. And so I hope that you see in a very simple explanation how today we're able to look at these things very precisely. And the joint is able to be understood both from a hard tissue and a soft tissue perspective. And we also can look at other components such as fluid in the joint, fluid in the bone marrow, which can build up pressure and cause pain. Now you notice here in red, I've mentioned Piper stage 4A and Piper stage 4B. One of the things that we will do in the course as you take it is that we will explain to you how we can stage these changes from absolutely normal all the way down to the very worst degenerative joint disease, bone on bone situation. And Mark Piper has described this in 5 stages. We use these stages to be able to communicate with each other, just like you can see in this case, when someone is off the disc and then opens their mouth and they click back onto the disc, then that's a Piper stage 4A, A meaning clicking. On the bottom screen where you see the patient is off the disc, and when they open, they do not recapture the disc or reduce onto the disc, then that would be a Piper stage 4B. So if you and I are on the phone talking with each other and you're talking about a patient with me, and I say, well, tell me what Piper stage they are. And you, after you've studied this and you've tested this and received imaging and a report back from the radiologist, and hopefully you'll learn to read these as well, then you might say, well, on the left-hand side, we had a 4A, and on the right-hand side, it was a 4B, and I'll know exactly what you're talking about. So part of our goal here is to simplify complex subjects. This certainly would be considered a complex subject, but we can simplify it and break it down to something that we all can communicate with each other and understand, and we can communicate with our medical colleagues as well and help them to understand. So here's another example of normal, and you see the disc on the sagittal view, which is the left-hand side view looking from the side, and the anterior posterior view where we're looking from in front on the MRI, and I've outlined the disc for you in both cases. Where on the other hand, here on the lower left, you see an anteriorly displaced disc, and again, on the lower right, you see an anteriorly displaced disc as well. And so very, very straightforward it is to begin looking at these. Here on the lower right, you see an image where I'm outlining the disc, but the arrow that's going horizontally, you see a big white patch or white area, and that's an area of fluid. So we're actually able to use MRIs in different ways. We can look at anatomy, as we've been showing you, but we also can look at fluid or edema or buildup of changes inside the joint that are also related to soft tissue or fluid type changes, which can relate to pain that can develop in the joint as well. Here again is an example of a joint where we can see the blue arrows are pointing to fluid in the space above the disc, and that is synovial fluid, which is the lubricating fluid. But now it's building up, it's pooling up inappropriately. On the lower left, you see the same thing. And then also there's other factors in the joint. As you're looking at the upper right-hand screen, the two arrows are pointing to, it looks like a divot or a depression in the bone, in the ball, or the condyle. And that depression, we actually call a cyst on the bone. And that's caused by fluid putting pressure on the bone, and the bone will remodel around that fluid accumulation. On the lower right, you see the condyle, and we're pointing to it with a blue arrow, the top half of the condyle or ball, and it looks dark. It looks almost black, the top half of that condyle. And that's actually an example of what's called avascular necrosis. Avascular necrosis is exactly what happens in hip joints of elderly that fall and break their hips, and you lose blood supply and the bone marrow area dies and you end up having a hip replacement. The same can be true in the temporomandibular joint. All of these are sources of pain in the joint, whether it's a disc displacement, buildup of fluid, bone death like avascular necrosis, are all common different ways in which we see people coming in with pain in their jaw joint. The point I want to make here is, here are some of the examples, but also I want to point out to you that we can go find those problems when they're present by using imaging. The other thing that can cause pain in the joint would be arthritic changes, no different than the illustration you see here of a knee, where you can get condylar surface breakdown of osteoarthritic type changes, and exactly those changes can occur in the temporomandibular joint. And so that can be another source of chronic pain, often low-grade pain in the joint. And as we look at CBCTs, which are excellent for looking at detail of bone, you can begin to look at all the different kinds of changes that can happen to the bone. And so these are arthritic type changes, and we have osteoarthritic wear and tear, breakdown, disc is lost, bone on bone, these types of changes, as well as rheumatoid arthritis, which, as you know, is more of a cellular breakdown in the joint space with Paneth cells and different degradatory cells eating up the joint space and eventually reaching the bone surfaces as well. So here's just some illustrations of some obvious changes that you can see in bone integrity that can go along with osteoarthritis and, in some cases, rheumatoid arthritis. So just like any other joint in the body, you can experience arthritic wear and tear and breakdown and disease. Another thing that happens in the temporomandibular joint, just like in a knee, would be to have damage to the knee because of injury. And so injury is a very common reason for pain in the temporomandibular joint. We have seen many patients through the years that have been in automobile accidents and had whiplash type injuries with crushing injuries in the joint that can tear the ligament attachments inside the joint and cause significant problems there. Well, we see exactly the same sort of thing happening in the temporomandibular joint. And so whether it's a whiplash type injury or a trauma like falling off a swing set or off a bicycle or having a blow to the jaw, all of these things can happen to the temporomandibular joint, just like any other joint in the body. And so we would call these acute type changes that can occur in the joint. But also we see chronic type changes that are very similar to acute injuries, but are not acute injuries. Let me give you an example. So in a runner's knee, there can be pain from the chronic repetitive loading and overloading of that joint. And the same can happen in the temporomandibular joint, just like a mortar and pestle on that joint that we often see in something we're all so familiar with, which is bruxism. So when you see wear on the teeth, there's force and overloading in many cases in that joint region that can add up over time in many people, and that can begin to break down the integrity of the ligament attachments of the disc to the bone, displace the disc, cause overloading, change in the joint. And so that would be more of a chronic wear and tear as opposed to an acute wear and tear that can cause these significant damages in the joint. So instead of macro trauma, in this case, we're going to call this micro trauma that over time adds up to exactly the same outcome. And so that's a common reason for problems of pain in the temporomandibular joint. And those would be the most common ones that would cause pain in the joint. Well, what limits the jaw from opening fully and may cause locking? And we come back now to this subject of disc displacement, because when the jaw opens and closes and the disc is properly aligned, then there should be free opening and closing of the joint without restriction. But when we see restriction and even locking, most often it's caused because of a displacement of the disc and the difficulty in some cases of recapturing the disc because of it getting bunched up in front of the ball as it tries to glide down and forward. Or the other thing that we see a lot is pain in the joint as a result of disc displacement. And now the muscles of the masticatory system will splint the joint and go into sort of a trismus or spasm, whereby they're shutting down the activity of that damaged joint in an effort really to protect the damaged area. So the neuromuscular system senses that damage, and just like we would limp on a leg where we have a problem, so we will restrict movement in the jaw joint as well. Locking can occur because of a disc that's locked out of place. It can occur because of scar tissue in the joint between the ball and the socket, where there's scarring across the joint surface. That can happen as well, both between the disc and the roof of the fossa, and between the condylar ball and the roof of the fossa or socket. And so those are things that mechanically can happen as well. So we see these cases often, and we see this image as an illustration where you see a disc that's bunched up. You see a lot of fluid in the area where the disc is displaced. That's creating a mass of really obstruction for the condyle or the ball to move down and forward on opening and closing. But also there's probably a lot of pain associated with that damaged joint, and the body will begin to lock it down in an effort just to protect it and immobilize it, which is very common. So there you see both the disc and the fluid and where the condyle is, and some of those things that can make it more difficult for opening and closing. So that leads really right into the subject of popping, clicking, or grating sounds while opening or closing. And we're coming right back now to that subject of disc displacement. It's been found that about a third almost of adults in the United States have a little click or tick or pop or click in a joint. So it's not uncommon for a disc to get partially out of place, usually just off the outside corner, not completely out of place. And so that very minimal reciprocal, meaning opening and closing click, is a very common finding all over the world. Actually, it's been averaged out that about 25% of humans on the planet have some type of click or pop in a temporomandibular joint or in both. The grating sounds are more associated with roughness of bone surfaces. So it wouldn't be very rare to see an elderly person come in who, when they open and close their mouth, if you feel with your fingers over the joint, you can feel a sandpapery sensation or even a grating. And I felt joints where it felt almost like a rough surface, a gravelly type surface in the joint. And that's just the end stage of degenerative joint disease with bone on bone that will get very rough. You'll even get sometimes little fragments of bone floating in the joint that can create some friction that you can pick up with your fingers or listening to the joints. And so that's the most common reason for that. And so as a disc gets displaced and you have reciprocal clicking, then you'll get that. And the grating is afterwards when the disc is completely displaced but not recapturing anymore. A very interesting subject that relates very closely to medicine and questions that you'll be asked by medical colleagues, particularly ENTs, is there an association between ear pain or tinnitus or tinnitus and the temporomandibular joint? And so I was very blessed to be able to study with Dr. Mahan at the University of Florida, who also had a PhD in anatomy and was a true genius in this area. And so in his studies back in the 70s, 80s, and 90s, he described a little communication called the petrotympanic fissure. And so it's a little slot between the bones that is sometimes open that communicates between the middle ear and the temporomandibular joint. So as I show you this on the left-hand image, you'll see I've outlined the temporomandibular joint, and there's the ear. And then right there, there's a little fissure of communication that can exist in some people called the petrotympanic fissure. And fluid can move in and out of that area and put pressure in the ear region. As you look at the right-hand screen, as you look at the white arrow that's pointing down, that white area that you see is in the petrotympanic fissure, and there's a lot of fluid in there. And so that's an illustration of how that can be true. And so if a patient goes to their ENT and says, I'm having ear pain, I'm having tinnitus, ringing in my ears, etc., and they check it out and say, well, your ears look clear, there's no infection in your ears, you may want to go talk to your dentist about TMJ or TMD, then this would be an area where that would be a possibility. What I would tell you as far as treatment is that very often you will get significant improvement when you treat the joint disorder with the ear issues, not 100% of the time. But if there's a true disorder in the joint, then it's very common that you can. And I found that in many cases, just using a steroid dose pack like Medrol, you often can reduce some of that, not tinnitus completely, depending on the source. But if this is the source of that, in many cases, you can get a dramatic decrease just by using a steroid and then treating the problem. Okay, so let's move on. And here are some interesting stats for you. In one study of 344 patients, 60% of the patients with temporomandibular joint disorder had ear symptoms. So over half had some ear symptoms. I would say that's a little higher than we saw in our population of patients, but it was very common. In another study of 400 patients, 42% had ear symptoms. 21 of 28 patients had relief of tinnitus following oral facial pain therapy, which would include possibly occlusal splint therapy, anti-inflammatory meds, muscle relaxers, and physical therapy. So this is a very interesting subject and one of overlap as we collaborate with our medical colleagues on these subjects, whereby they may be seeking our help as dentists and dental professionals. How is TMJ a major cause of headaches and neck pain? Well, something we found, and now we're really looking at this cross-link between another pillar, which is airway. We found that when patients have pain in their joints, as I've already mentioned, it's very common for the muscles of mastication, both starting with the posterior neck, anterior neck, elevator muscles of closure, and the lateral pterygoids, which are positioner muscles of the jaw joint, to see all of those to be very tense and tight, and for there to be clenching and tightness of the elevator muscles, such that, you know, on opening, it feels like it's really stretching and uncomfortable, but also the temporalis muscles will be very sore. Posterior neck, occipital region will be very sore, radiating over the top of the head into the temporal area and across the cheeks on both sides. So it can be a major source. I will say to you that in our discussions with hundreds of TMJ patients, I would always ask, do you have any neck problems? And I will say 75% of the chronic TMD patients would say, my neck is killing me. It bothers me all the time. So we saw a very close connection. We felt like in the early days that it was probably due to posturing, trying to get away from the pain that was in the joints, and that you would go into a forward head posture, just trying to find some relief. In recent years, as we've been learning more about Airway, which we'll talk about next, we found that Dr. Christian G. Minot and their group at Stanford University have studied this for 40 plus years, have told us that when we have patients that have airway, breathing, and sleep disorders, it's very common for them to shallow breathe from the chest, and even as children go into a forward head posture with labored breathing in this chest area, and that can create a forward head posture, which is typical in patients with upper airway resistance syndrome, and even many patients that have sleep apnea. And so today I would say TMJ is definitely a source of headaches because of the pain that comes from the joints, the protection that comes from the muscles around the joints of the masticatory system, possibly forward head posturing, trying to get relief from joint pain. But also we would want to throw into that discussion, could there be an airway problem as well that could be also exacerbating the forward head posture? And so that also could then add into the posterior anterior neck problems, temporal problems, etc., clenching and bruxing, as we'll talk about more in just a minute. So there is definitely overlap there, but TMJ is a major cause of headaches and neck pain. The sixth topic would be the impact of airway obstructions on the TMJ. Really interesting subject, something I didn't know about for 30 years easily until the last 10 or 11 years, as we began having more in-depth discussions and learning more about airway, and the fact that airway obstructions will cause labored breathing. Now we get into more bruxism issues, as we'll talk about next, in an effort to open the airway. That can create more loading of the system, of the temporomandibular system and the joint. And so not only do we have teeth damage and overworked muscles, but also we have overloaded joints in the temporomandibular joint region. And so it can definitely have an impact on TMJ. I want to add to this a few things that have been noted in the literature in this Journal of Dental Research in talking about sleep apnea symptoms and the risk of temporomandibular disorder. A cohort looked at many studies that were done and came up with these overall conclusions. There's an emergent body of evidence that suggests that obstructive sleep apnea, today I would say we would also include upper airway resistance syndrome, that is labored breathing without being full-blown obstructive sleep apnea, is associated with chronic pain disorders, including temporomandibular disorder, which they define here as a musculoskeletal disorder characterized by persistent pain in the joint, in the periauricular region, and in the muscles of mastication. They state that there's an association statistically significant with 73% higher incidence of TMD among people with a high likelihood for obstructive sleep apnea, and I would add upper airway resistance syndrome. So you see our three pillars of integrative dental medicine are really right on target for trying to understand the overlap or the linkage between common problems and common symptoms that our patients present with, both medical and dental wise, that are very important. So this subject of TMD and obstructive sleep apnea or upper airway resistance syndrome very much becomes a chicken and egg question. Which started first? If you had an airway problem, you had inflammation in your airway and your esophagus and your throat, then certainly that's going to compromise your breathing and would add to more bruxism and effort to open the airway and more overloading of the system in the joint. If you have a joint problem where you begin to get breakdown in the joint, then that's going to shift the mandible backwards and compromise the airway. And so it's been well documented that airway breathing and breathing related sleep disorders are a major concern for masticatory instability. It's also been shown that they can often be the why behind bruxism, behind worn teeth, behind sore muscles, behind morning headaches, behind dental malocclusion, and chronic fatigue. And so you see this overlap we want to be always paying attention to. I want to point out another study or input that we had. I wrote an article in 2020 for Inside Dentistry about dentistry's role in airway screening and treatment. And I interviewed a number of experts. I really recommend this article to you called The Wake Up Call, and it's in January of 2020. You can look it up on the internet on Inside Dentistry. But I interviewed Mark Piper, who, as I mentioned to you, is an MD. He is a maxillofacial surgeon and has probably done more TMD surgery than any surgeon in history. And he worked with us in our group here since 1983. And so Mark, in his very brilliant way of analyzing things that are biologic and in the human system, describes the masticatory system as we look at it this way. And I think this will be really insightful for you as it was for me. He says the maxilla, the mandible, and the cervical spine define the endoskeleton, that is the hard structures for the oral pharyngeal vault. So everything inside of the upper and lower jaw, everything inside those two and confined by the cervical spine in the back is where all the soft tissue and the airway have to reside. So we've got the soft palate, we have the tonsils and adenoids, and we have the airway, all and the tongue, all occupying one vault. And there's only so much room for all of it. So if you get a compromise in any way of not only soft tissue, but also of bone, then that can be very important. And so Mark goes on to say in this article, as goes the condyle, that is the temporomandibular joint, so goes the mandibular, the lower jaw projection forward, out, and the oral pharyngeal vault dimension. So how much room is there inside that bony limit or border? Children with disc displacement risk deficient condylar growth and reduced oral pharyngeal vault dimension. And in adults, dentists should diagnose the condition of the joints and their foundation, the stability of the mandibular condyles in their assessment of the oral pharyngeal vault. In other words, if we're going to look at airway problems, then we need to look at the jaw, and that is the joint, and the dimension of the mandible, and the dimension of the maxilla, and how much room there is created or not created by there being sufficient development of these bone structures or insufficient development or breakdown of those things. And so Mark has found that when you have breakdown in the temporomandibular joint, you have a disc that's out of place, you have a bone that's breaking down, you have arthritis happening there, and the mandible's moving back as it breaks down in the joint region, then you're compromising the airway and more likely to develop airway problems, more likely to develop upper airway resistance, more likely to develop obstructive sleep apnea because of that lack of sufficient space. And so I find that a very, very fascinating discussion. And here's a good example. So this is a patient of mine, Audra. And Audra comes in, and if you look at her, you can see as you look at her face that it looks long. It looks like she's having to work just to get her lips together. Her lower face is longer than it should be. Her cheekbones look poorly defined. Her muscles look long and not strong and square. If you look from the side view, you can see her mandible looks like it's retrognathic. And then here's her bite, believe it or not. She's closed down right there in that picture, and she's only touching on her second molars. So this is our next patient. How are we going to analyze this? This is really challenging, isn't it? How did she get like this? And there's a couple of ways that she could have gotten like this. Could it be that the soft tissue issues, such as her upper airway, nasal airway, could have been blocked with congestion and allergies, and therefore she converted to mouth breathing, and the soft tissue of the tongue began to protrude forward and go between her teeth, and she developed an anterior open bite because of dysfunctional breathing? Well, that's possible. But is it also possible that the hard structures of the endoskeleton, in this case, I'm thinking about the mandible, that could there have been breakdown at the joint level where maybe she's off the disc, maybe the bone is breaking down, maybe the mandible is swinging back, and therefore she's now only able to touch on her second molars because of the deformation due to breakdown and damage and disease in the joints that are causing a problem of this retrognathic anterior open bite situation. And so could it be either one of those? And the answer is absolutely. Could it be both of those? And the answer is absolutely. So let's look more closely at her. I'm going to look at her face and a retrognathic and anterior open bite, and then we're going to go get answers. We're going to go ahead and do testing. Let's start with CBCT and see what we can learn. So here we look at her CBCT, and as we look at her joints, I can tell you, and I hope that you can see, that the ball in the socket is gone on both the right and the left. It looks like the ball just got lopped off at the neck. She's had so much breakdown in her temporomandibular joints. She doesn't even have temporomandibular joints anymore. She's probably lost 10 to 12 millimeters of height of bone in the back of her jaw, and her jaw has swung open that far in the front as a result of that. So she has severe joint breakdown on both sides. That can fully explain what we're seeing in her occlusion. But we also are interested in her airway. So let's look at her airway on the CBCT as well. And if you look at her upper airway or nasal airway, you see as her nasal airway has collapsed really, then her breathing through the nose is literally impossible. She cannot breathe through her nose. That's completely collapsed. You see a deviation, you see a S shape in her septum. So she has a deviated septum. And then in her posterior pharyngeal area, in her throat area, it's very constricted and very narrowed. We can look at this from a imaging software perspective, and where you see the orange in the back of her throat, that's where her airway is very constricted. And so we can clearly see that she's had both an airway and a joint problem, and both combined together. Two of our three pillars in integrative dental medicine, then you're seeing overlapping here or interacting with each other as we're trying to diagnose. Let's move on to the seventh subject topic, and that is bruxism. And what causes bruxism? I've seen hundreds and hundreds of patients in my career that were severe bruxers. The worst is probably the one that you see on the right-hand photo there, who was a physician from South America that came up to be restored, and his incisive papilla upper and lower were actually touching. That's how much wear there was on those teeth, just incredible. And so we have seen hundreds and hundreds of patients with severe wear, and we see severe wear in children too, don't we? And so the question is, what causes patients to brux? There's a number of reasons, but I'm just going to hit on the most common ones that are known to be scientifically sound reasons. And one would be oxygen desaturation, which comes from airway obstruction, such as obstructive sleep apnea and upper airway resistance syndrome, have been shown to be triggers for bruxism, clenching and grinding. Also, a pH drop in the esophagus has been shown to be a trigger for bruxism. And we see that, don't we, with gastric reflux. A question was submitted before our study club meeting tonight of, is there a relationship between gastric reflux and TMD or airway problems? The answer is absolutely yes. Absolutely yes. It's very common for us to see patients that brux, patients that have temporomandibular disorders, and patients that have gastric reflux, and patients who have airway problems. Many believe that when there's an airway obstruction, there's an effort to breathe, but not very effectively, that it actually can create a reverse pressure coming up from the abdomen that will bring up gases and acids from the stomach through the esophagus, as we call that GERD. And so very, very common. But those are the two most commonly understood scientific reasons for a bruxism. But I would add to that neurologic problems such as Parkinson's bruxism, where it's a neurologic problem, and medications and recreational drugs that are very commonly shown to create bruxism. So that would be another medical reason. And bite changes can also cause bruxism activity when we're touching on teeth that don't feel even, and there's an effort to shift or to erase that. And so that would be another common reason. So let's wrap up this discussion, and then we'll have some interaction with each other on what would we say would be the treatment options for non-surgical management of TMJ disorders. The most commonly used ones, as we're familiar with, would be occlusal splint therapy. The purpose of occlusal splint therapy is to try to coordinate a damaged joint with muscles that are overactive with occlusions that don't fit. And so if we can seat the joints, if that's possible, without discomfort, and have the bite touching very evenly, it helps to normalize the muscle activity in many cases and can help to stabilize these problems, all obviously depending on the severity of the problem. So that's a very common dental solution for this medical type problem. Physical therapy can be very helpful as well, with mobilization, with muscle relaxation, with working with inflammation, etc. Laser therapy has been very successful in treating acute pain as well as chronic pain through some of the wonderful things that laser therapy can do in regenerating and reducing inflammation. And then also occlusal correction is something that we have done. So medications are also useful in some cases with anti-inflammatories, muscle relaxers, etc. And so those are just the broad scope of how we in dentistry would work with treating these TMJ or TMD type problems. As far as surgical management of temporomandibular joint issues, depending on the severity of the problem inside the joint, then one option would be to do arthroscopic arthrocentesis, which is basically flushing out the joint of inflammatory fluids and floating bodies in the joint that can cause irritation and inflammation in the joint. This will never correct a disc displacement. This will never cause the disc to jump back into place. And so when that irreversible damage is done, then I would say arthrocentesis can have a limited amount of success, and it may be short-term improvement, of acute pain or chronic pain, but is not a reversal or a permanent solution in most cases. When a disc is out of place, there's a variety of procedures that are done to repair the disc. In some cases, putting an anchor posteriorly in the condyle to tie down. And if possible, then the disc is tied down to other structures that are naturally occurring. I won't go into detail, but so a disc repair when a disc is out of position is ideal when the disc is repairable. If the disc is shaped normally and hasn't been out of place too long and there hasn't been too much damage, then a disc repair is possible. In some cases, the disc is removed and some substitute for the disc can be put in, like fat grafting or muscle grafting has been done successfully in a number of offices around the world. In the most severe cases of joint breakdown, such as I showed you in Audra earlier, where there was no condyle left, there was no disc to work with, then replacing the joint like you would do in a joint replacement other places in the body, such as a knee or hip replacement, is something that's being done today very successfully. So in the worst case scenario, we can use imaging, we can use scanning, we can put all that together to customize jaw joint replacements. And we've seen some very successful, comfortable, good mobility outcomes in our patients through the years that have had complete joint replacement. And sometimes that's what we need to do. Here's an example of a young lady I just completed treatment on in the last 2 weeks. So she had a terrible accident, broke her jaw in multiple places, broke a number of teeth. And so she went to an oral surgeon, was wired together. They put a plate in her anterior region of her mandible. When she came to see us, we did further investigation and we found through the imaging that she had some very serious problems. In fact, as you look at the CBCT on the lower, can you see where the condyle at the neck has snapped and the coronoid process going up under the zygomatic arch has also been shattered and snapped on both the left and right side. Well, when you have a condyle fracture through the neck, then you're going to lose blood supply and develop avascular necrosis, and there is no turning back. It would be like splitting a tooth all the way down the root. And so in this case, we elected to do a complete joint prosthesis replacement, which she had done nearly a year ago. Then she went through ortho, and now we've just completed her restorative dentistry in the last 2 weeks, and she's very stable. So this is kind of your worst case scenario, isn't it? And so I wanted to show you these things, and I'd love to talk about this some together and really entertain any thoughts or questions that you all would like to talk about regarding these topics of temporomandibular disorders, TMJ issues. And so why don't we open it up for some discussion? Let's see if you all have any thoughts. If you want to just ask questions. Mike has asked a question. He says, I get referrals for TMJ treatment by an ENT. When I refer back to rheumatoid sleep disorder, the MD gets upset with me. Should I just treat the TMD or insist on a sleep test? Do you want to speak more to that, Michael? Well, I'll just go ahead and answer. So an ENT refers for TMJ, and so do we need to refer back to the ENT for a ruling out of sleep disorder? I would say no. If I'm evaluating a TMJ problem and I feel there's a possible sleep component to it, then at least in Florida and most states, we would be allowed to order or run our own sleep study. If we do a sleep study in our office that results in the obtaining of an AHI and apnea score, then that has to be interpreted by a physician. And so we would work with the sleep company that we're running the test through and ask their sleep physician to interpret and send us a report. That then could help guide us, but we could also share that with the ENT and tell them that this is part of our TMJ evaluation. If you don't want to run those in your office, you can refer those studies out to a third party, like Blackstone is an example of a company that you can refer a patient to, and they'll send a home sleep test to their home, and they'll run the test for 2 to 3 nights, get it back, interpret it, work with them, work with their medical insurance, and then send you a report. And so that is how we would handle that. You ask, should I just treat the TMD or insist on a sleep test? No, I think because the TMD can be related to airway and sleep disorder, then I would include that as part of our therapy. And then also the question is bruxism the main cause of degenerative changes in the condyles? And we alluded to that somewhat. And I would say, as far as a main cause of degenerative joint changes, I think it depends on the susceptibility of the individual. There have been studies, and there was a large study done in Israel saying that overloading of the joint can cause degenerative changes of the condyles and a breakdown of the soft tissues and attachments, and even make patients more susceptible to disc displacements and this sort of thing. But I would say the main cause of degenerative changes in the condyles would be disc displacement. So when the disc is intact on top of the condyle and you have synovial fluid nourishment bathed across the top of the disc and underneath the disc, on the condyle, on the fossa, on those bony structures and the fibrocartilage that covers them, then they will remain healthy, typically, if they're being well nourished. And so it's the lack of nutrition that comes from disc displacement and the inadequate distribution of synovial fluid and pressing of that synovial fluid down into the fibrocartilage surfaces of the bone that is the main cause of degenerative changes in the condyles. The question says, what is the bruxism pattern on O2 desats? In other words, do you see a particular direction of bruxism? Remember, bruxism has 2 parts to it. Bruxism is clenching and bruxism is grinding. And both of those are just overloading force and extra use of muscles, bringing the teeth together forcefully. So some people will brux by just clenching, and some people with O2 desaturations will just simply clench. You'll see no wear facets or wear patterns on the teeth at all, and yet they could have a very serious oxygen desaturation and even serious sleep apnea. So look at your patients who have the great big masseters, but don't show any signs of bruxism. When they've got those great big masseters from clenching so strongly, then I would be suspicious that there could be an airway problem. A friend of mine here in St. Petersburg that I used to tease about the fact that he had world-class masseters, and if there was ever an Olympic event, for the size of your masseters, I was going to enter him in the contest or the event. I began studying sleep apnea and airway problems, and as I understood that clenching can raise the hyoid bone and in some cases help to open the posterior pharyngeal area in some patients, then I realized that my friend Andy very well could have that. So I had him come in. We did a sleep study, and he had severe sleep apnea with not one sign of wear on his teeth. On the other hand, when you do see signs of wear on the teeth, I would say that it's very common with oxygen desaturation bruxism that you're going to see patterns that have to do with opening the airway. So if the posterior pharyngeal airway is blocked by the tongue and the mandible and soft tissue there. And there's an effort to do self CPR and move the mandible to open that posterior airway. Most likely it's going to be in an anterior direction. If they're sleeping on their side, left or right, it may be anterior and off to the opposite side. So if they're a left-hand sleeper, maybe it's going to be more on the right anterior corner. If they're a right-hand sleeper, maybe it's going to be more on the left anterior corner. Or they may come straight forward and you see a lot of damage on the incisors as well as canines and posterior teeth. Okay, Mike, we'll see you in the TMD course. Other questions? Laura, you want to jump in and comment just on things that you've seen and questions you've heard, perhaps? That would be good.
Yeah, I think you're covering it. I think the biggest thing from just the hygiene share is we see that wear, right? Or we'll see the abfractions and things that we're taking our intraoral photos and almost unaware of what those signs and symptoms are. And I think it just kind of takes us down the path of like, get a photo of the airway. Can we see the uvula? Can we see the tonsils? Can we see the back of the throat? As we're doing some of those photos, you know, like you said, we just see that so often that I almost think patients and just colleagues of mine, we almost take it for granted. Like, well, everyone has wear on their teeth, instead of really taking a look at, right, keep asking, I guess the right questions is what I want to bring up. Maybe some of those questions go over, you know, we talk about the high palate, narrow, you always go through that.
Yes, exactly right. And Joe Gaudio is bringing up a great point, and that is that bruxism is also part of a movement disorder. Jerry Simmons in Houston has pointed that out to us, like restless leg syndrome or limb movement. But that in his work also goes back to airway, doesn't it, Joe? And so that becomes a very important part of that. And what Dr. Simmons found was that when they were able to open the airway, such as using a CPAP, that many times the bruxism would just cease. Very much like what we have seen in children who have tonsils that are blocking their airway. And when the tonsils are removed, you know, then they often will cease bruxing, at least a very high percentage. Now, if we can get their mouth closed and get them nasal breathing again and eliminate their allergies and expand their arches, then you're really in business. But these are all things that are connected. And of course, with bruxism comes TMD. So how do you differentiate them? It's a chicken and egg type issue. And when you develop malocclusions, such as when a joint's breaking down and we're touching on back teeth only, we see more bruxism then too. Sometimes in an effort to try to find a place to land or to find, you know, a place where we can bite together and it's not uncomfortable or we're not overloading a tooth. So all of these things are what we want to be acutely aware of. The question here says, I've heard anterior guidance, that is front teeth touching when you move your jaw forward, left and right, protects the teeth, but isn't good for damaged joints. Do you agree? So group function of posterior teeth on a splint might be the best way to treat. And I would totally disagree with that. Anterior guidance is always preferred, whether you're working with an appliance or with a natural teeth, because of the fact that it's all about muscle activity. And so when you separate the back teeth, going left, right, or forward, you're going to automatically reduce muscle activity dramatically. And so whether it's in a splint or in natural teeth, we always want to get the back teeth apart as fast as possible. So when the joints are seated, we want all the teeth to touch, because that shares the loading forces of, let's say, biting or even clinching, and distributes it more around the front end of the system rather than through the joints, which may have damage. So that's a good factor of total occlusion on as many teeth as possible. And then when we move away from the seated joint position, you want to get the back teeth separated instantly. and that would be on anterior teeth. So if you do EMG studies, electromyographic studies of muscle activity, there's been a multitude of studies that have shown us that when you touch on back teeth, you can load up with muscles nearly 100%. When you press down or grind on canines, you can create about 60% of maximum muscle force. When you touch only on incisors, that goes down to only 20 to 30% of maximum force. What we're trying to do is reduce forces to protect joints, reduce forces that go through the joints. When you introduce back teeth like group function, which is really a denture concept, that really isn't a good concept for all teeth being present, except in extreme cases where there's no other options and we need orthognathic surgery or something like that, then we're always going to choose to use anterior guidance, that is anterior teeth only touching as soon as you leave the seated joint position. Allison says, Dr. Pete Dawson used to say, ask why until you can't ask why anymore. That's exactly right. And that's what we're doing in looking at so-called TMD, which, by the way, is not a diagnosis, is it? TMD is saying almost anything above your shoulders that's bothering you could be called TMD. Headaches, sore muscles, clicking and popping, locking, grinding, all of those things. So TMD is a basket syndrome, and Dr. Pete Dawson would say, when you say somebody has TMD, it's like saying they have a case of stomach or they have a case of elbow. It really doesn't mean anything. And that's why our job is to do what you're saying, Allison, and that is ask why until you can't ask why anymore. That is diagnose, diagnose, diagnose. And that's very important. Joe Gaudio says nasal resistance is a big part of all of this and compromised nasal valves. Yeah. Joe, if you want to unmute, go ahead and speak up to this.
Yeah, and this is basically coming from the work that Steve Almos has brought to the table. He put out a paper last fall about the nasal valve compromises and that airflow limitation and/or nasal resistance, which actually can be a big component of triggering the nervous system into that fight or flight. And that's just basically a stimulation of that nervous system response, and can lead to autonomic arousals, can lead to issues that will just add to all of this with regards to the nocturnal bruxism being more than just a mechanical issue of occlusal muscle conflict.
Yeah, great. Okay. Supriya says, if what you're saying is true about anterior guidance, I think, how is the pod prevented oral device effective for TMJ? Great question. And we could get into a long discussion about that. But basically what that is it's like a pad that goes between the back teeth, and it opens the vertical up. And the way it was originally described, and we could have a long conversation with this, and I don't want to get into controversy particularly, but originally, I don't know what's being said about it now. Originally, the concept is that it helped to disengage the joints, meaning that when you put a pad between your back teeth, that the joints were going to have to come down, and therefore you're disengaging or you're unloading the joints, which should make the joints feel better. And I think that's the concept of that. Dr. Dawson would argue that the muscles of mastication are behind the second molars. And so when you bite down on that, you're still seating the joints because of the leverage effect of that. And so then there was a dentist in New York City named Dr. Harold Gelb. And Dr. Gelb used to use probably what we might call the first pod. And that was what he called the Gelb appliance, which looked like a lower partial connector around the linguals of the lower anteriors. And then there was an acrylic pad that sat between the molars or the posterior teeth on the bottom. So it would open the bite up where you would only touch on this acrylic pad in the posterior. The anterior teeth were wide open. and that was used to treat TMJ and was touted as unloading the joints. It didn't unload the joints. We can show that with imaging that did not unload joints. But I think what it might have done is open up the airway some. And so is it possible that some of the things that we're talking about for TMJ are actually improving patients' symptoms subjectively because of the fact that they're actually breathing much better? So we could get into a long discussion, and that, we won't do tonight, but just something to think about. And Mike Steinberg talks about the aqualizer. The aqualizer, yes, the aqualizer is a water-filled pad that goes between the molars, but it's just a cushion. And so that's a complete different discussion than occlusion, in that all it does is it helps to just kind of soften when you close on these soft water-filled pads. And yes, I've used that on many, many, many patients through the years that have internal derangements in their joint and they're off the disc, and they will say that it does help give them some relief. And so is it just that it reduces loading of the joint? And I think maybe that could be true. So great discussions. And here's what we're going to do as we, I'll share with you how we're going to get into a lot deeper discussion on all this in the future. So let me move forward to the last couple slides I want to show you, and the discussion I want to have together with all of us, and Laura will chime in on this, but let me tell you where we're going. So hopefully that's been helpful for you tonight, just to whet your appetite on this subject of TMD and airway, and two of our three pillars. But here is our present format in the IDM Scholar Society. We will have annually our Revolution Symposium. And as study club members, I'll share with you as insiders that this is really intended to just be a 2-day teaser for us to begin to learn new things that are going on in this field that we're talking about, and to hear from people that are doing unique things and are on the cutting edge and that we want to learn more from. And we want to begin to incorporate new concepts into what we're doing. It's also an opportunity to bring new people to events that we're doing to understand what this is all about. And so it's very parallel, but not meant to replace AOSH, the American Academy for Oral Systemic Health, which meets in September. And our symposium for IDM will meet in May. So we're always trying to keep it 6 months apart from the AOSH meeting, because we're huge supporters of AOSH. As you can see, we listed in the lower right-hand corner as part of what we see as what we are all about, is to support and participate in AOSH. What I want to share with you that we're very excited about is that we have just become involved, IDM Scholar Society, with a new dental school. And so, Laura, tell us, we've got 8 minutes, but just give us the 3-minute version of our relationship with LMU and how that's developed.
Yeah, so we were contacted by Lincoln Memorial University because they are going to be one of the first universities where they are actually putting in their curriculum oral systemic integration. So just what we're teaching you here, they're actually going to be starting to teach their dental students and hygiene students. So we couldn't be, I'm going to say, more really proud, and I'm going to say excited to be part of this. That's really creating a movement throughout the country. You're going to start hearing more and more universities. I do have to say, if you haven't seen on what's Instagram, go there and just look at the tour of the school, just the cutting edge technology. I mean, I looked at it and I was like, it makes you want to go back to school. I mean, just the anatomy tables, it's just unbelievable. But I think the biggest thing is to realize that this movement is taking hold and the future of dentistry is changing.
Yes, it is. And Dr. Denise Cook, who is the dean at Lincoln Memorial University, is committed to creating the best dental school in the United States. And she knows that means salivary testing, home sleep testing, these, periodontal protocols, et cetera, all the things we're talking about have to be part of it. So they're just in their second year of existence. They have, I think it's 80 students in the first and second year class, and they're committed to teaching these concepts to their students. They also have a medical school, a nursing school, and a dental hygiene school, all there in Knoxville. And they're talking to each other in collaboration to develop something really special. So we're so thrilled that they want to team up with us. And so what we are doing is we were planning to have a symposium here in St. Petersburg the first weekend of May. And we've changed that now because of this relationship. We're going to do it in Knoxville at the medical school at Lincoln Memorial University, where they have a large, brand new state-of-the-art auditorium for medical education. And we're inviting professors and deans of other dental schools to come to this, which will be a national event. And I sure hope you all will come, because it's going to be really fantastic. And we've got some amazing speakers, which we'll share more with you about who's coming to speak as we pin down this event. But it's very exciting, and it's kind of a breakthrough event. And we're just so excited to be part of it, and excited for you all to be part of this, on the very leading edge of it as we do that. So that's one thing that I wanted to share with you tonight. Yes.
The dental school at the Dental College of Georgia is just starting to introduce this. I've introduced it to the residents already in a presentation. The head of the undergraduate wants to include it in that curriculum, and we'll do more with the graduate curriculum. I'm adjunct faculty at the Dental College of Georgia, and so they've asked me to kind of spearhead those things. It sounds, not of the incredible start that at Liberty, but I'm getting started. I would love to have access to their curriculum, just to even just a syllabus of what they're doing and things like that. So if you could help me, get into that kind of thing and collaborate a little bit, that would be fabulous.
Yeah. And theirs is actually just being developed now too. So we're having a lot of communication with them about that. So very exciting. The other thing, since we met 2 months ago in October, is we have now finished our online courses. So I'm trying to advance this. There we go. Our online courses. Go back one. Sorry. There we go. There. So in November, as you may have seen, we released our Airway Foundations course. And then December 1st, we released our TMD Foundations courses. So all of those online courses, from the Foundation Seminar, the Inflammation course, which was put out this summer, Airway and TMD, are all available online. And for anyone who, may need to learn at home primarily and isn't free to travel as much or be out of the office as much, etc., then this is designed to really help establish, a good, strong foundation, and exactly what it says for anyone who's interested in learning more. The other thing I want to point out is that we are going to have our first advanced workshop on Airway and TMD. So you see that we have the Foundation online course for Airway and TMD, and that gives you all the basics. But then this advanced workshop is going to be the hands-on stuff. And so it's strictly dedicated to, what do you do in the office? How do you interpret that? How do you make this? Let's do it on each other for 2 solid days. We're going to work around the clock. And that is January 26th and 7th. So I hope that that's something you'll sign up for. We'll have a limited attendance. I want you to notice sunny St. Petersburg. Okay. So all of you that told me it's in the 30s, it's getting ready to snow, wait till January. It's a perfect time to get away. So come see us in St. Pete. And we'll have a great time together learning. And I'm very, very excited for us to get that started. Then the other thing, and we're out of time, but I wish we had more time to talk about it tonight. I want to respect our time and finish at 9:30 Eastern, but we've started our OASIS program, which is Oral and Systemic Integration System. Basically, all of these tracks and putting it together in such a way that we can help team members who want to become care coordinators in their practices. So that could be a hygienist or a dental assistant, but that want to coordinate these things and make it flow for their doctor in such a way that, you know, they can integrate these things without taking a lot of chair time away from the doctor. Then that's what this is all about. And there's a whole track, including a lot of individual attention and Zoom calls that you can learn about with that. And then we also are developing or offering our track for a fellowship track for those of you that are gung-ho, want to go through everything that we have provided. And our first fellow is going to be Dr. Mike McDivitt. And so we're so excited. You heard from Mike for what he's doing at the Medical College of Georgia. And Mike is one of the best known periodontists in the world. He is in Atlanta, Georgia. He's the go-to periodontist in Atlanta. He's been the periodontist advisor at the Pankey Institute. We've known each other for 40 years, and there's no one I respect more than Mike McDivitt. And he wants to begin coaching these things that we're talking about, is 110% on board. And we're just so blessed to have his involvement. And he's going through all of these courses right now and going through them first and giving us feedback on them so that we can fine tune and improve what we're doing. And Mike, we're just so thrilled to have you on board and to be our first fellow in the IDM Scholar Society. So
it's
Laura?
my huge privilege. Thank you.
Well, it's just a match made in heaven. Laura, I think our time is up, but you guys, we love you all. We are so proud of you. We're so excited about the future. We hope that you're seeing things here that you want to jump in on and participate with us in. We've worked really hard to try to make you successful, and we just wish you the merriest of Christmases and happy holidays and happy New Year. And we look forward to seeing you at the beginning of the year at one of these events and throughout the year of 2024. So, Laura, you want to say goodbye before we sign off?
Just want to say happy holidays, and those that are part of our OASIS program will continue to have our office hours on Wednesdays, and just so excited to see you guys at our next event at the first of the year. So enjoy your holidays and your family.
All right. Take care, everybody. God bless you.
God bless you. Thank you.
Thank you.
Many Christmas blessings, Laura and Whit in particular.
Yes.
Thank you, Mike.
Right.
So much, Mike.